Morning. Thank you very much for that introduction. I completely agree. And I'm mindful that I'm standing in front of an audience where you probably have mixed experiences of involving our specialty, that is palliative care, within your practice. So, one of the challenges I've got today is covering something in 20 minutes plus when I can talk about each of those perhaps all day. Those topics that will be just very briefly skimmed upon for you to be able to kind of ponder about at the end of the day, if anything, and hopefully keep you interested enough to think about reaching out for palliative care earlier. So, very briefly, it will be about the specialty, what we do, because there's usually an impression that you call us when everything is done and dusted from gynae-onc management. A little bit about a tool that you could use to identify which patient might need input from palliative care in a timely manner, and reviewing plans. Very, very brief overview of pain management. There are quite a bit of, there are lots of symptoms that come with gynae-oncological malignancies, but we only have time to very briefly touch on pain. A little bit about the document that came out in 2014, One Chance to Get It Right, which is national guidance around care of the dying patient. And a couple of cases to provoke thoughts around what might be barriers to recognizing dying. That's the WHO definition. And the most important bit that stands out about palliative care as an approach, it's about improving quality of life through early identification of problems that we would anticipate with life-limiting illnesses. Because unless we identify them early, we won't be able to support them. And when we talk about problems, the palliative care specialist is in a position to look at the person on the whole and proactively look for problems that would impact the four domains within life, as in physical, psychosocial, and spiritual. So the most important thing to remember is there is no mention of prognosis. The key words are, do they have a life-limiting illness? And do they have problems that we would expect within that life-limiting illness over time? Spectrum. As I said, prognosis does not count to consider palliative care input, because from the time that a person is diagnosed with a cancer that is likely to be progressive and already has metastasized, they are likely to have problems that would benefit from proactive intervention support to help them have a better quality of life. So as you can see, the role of a palliative care specialist spans the whole breadth of that patient or individual's disease journey. In the context of terminology, end-of-life care is a term that's used when we expect that a person could potentially deteriorate any time within the next 12 months. So when I'm approached and I'm told, oh, we've got a patient who's end of life, I always check, do you mean they have got months, years, or do you mean that they're in the imminent stages of the last weeks, days, hours of life? The one thing I would request all of you to look at is that care of the dying is a tiny bubble at the top end. So that's only a small proportion of what palliative care as a specialty deals with. If we are asked to support a person at that stage, we've missed a lot of opportunity to help them. So, one of the things that's been really reassuring as I was preparing for this talk is that over the last 5 years, there's been a lot more literature out there highlighting the need to refer earlier on to palliative care. It is understood that women with advanced gynecological malignancies suffer with significant symptom burden throughout their disease journey. And it's not just physical, it's psychological as well. So that first paper was published in 2021. It goes as far as recommending palliative care to be offered alongside life-prolonging or even curative treatment, not just at end of life. And the second paper also highlights the need for involving palliative care because it allows goal-concordant care to reduce, limit suffering, as well as limit the use of futile, invasive measures towards the end of life. National recommendation, all healthcare professionals are expected to encourage shared decision-making. It was very encouraging and reassuring to hear Tracy's talk first thing, because I was like, yes. And I apologize if I'm preaching to some of you who are already converted. One of the things, in fact, just yesterday, I spoke to 2 different gynae-oncology consultants about a patient that's currently under our care. Gently requesting that it's not just about the risks of treatment that we need to warn our patients about. It's also helping them understand what kind of problems they might face when the disease progresses on treatment, and when they reach a certain stage in their disease journey. For example, in the case that we're dealing with currently, we have a 75-year-old lady who had active treatment for uterine cancer, stage 3, and she unfortunately developed gastric outlet obstruction because of peritoneal metastasis. Family were completely upset that, in their eyes, overnight, she cannot have anything to improve her nutritional status because she's got obstruction, and they'd operated on her in September. It was an open and close. They realized that significant disease progression had happened. So the conversation I had with my colleagues yesterday was, they acknowledged that the family hadn't been prepared for that possibility. Whereas we know, seeing gynae-oncological malignancies, unfortunately, it does happen, particularly in the last stages, that they develop either bowel obstruction or go into ascites, and they could have problems. So when we're talking about shared decision-making and helping a person understand what to expect, it shouldn't just be limited to what to expect with regards to treatment side effects or treatment-related problems, but it should also include what can happen if this does not work, particularly in the context of advanced disease at time of diagnosis. Palliative care specialists, nurses, those of us in the field often find ourselves having to remind our colleagues gently now and again that if we pursue aggressive interventions, doesn't have to be expensive, even keeping people in hospital for intravenous antibiotics or acidic drains or whatever, and not getting the conversations in that this could be their last admission, would potentially end up prolonging dying rather than improving survival. So why call upon us? I've been in this field since 2010. I was aspiring to be an oncologist and was just trying to get through my exams. I ended up doing a hospice job, and within 2 weeks I decided that was it, this is what I'm meant to do. The reason is simple. We all love stories, and it's really important for us to have the experience of a good ending, whether we watch a movie or whether we read a book. I'm mindful of the fact that we look after people, And it's incredibly important that we enable them to have a good ending of their own individual life story. And very often people suffer, and this is not just cancer, non-cancer reasons. And when we're aware that they are likely to go through a tough time, it's incredibly important to make sure that we're optimizing whatever experience they're going through. So the palliative care specialist are not just handholders at the end or tissue suppliers. We're there to support the person with clinical skills, because knowledge is incredibly important to know what's the best intervention that's possible to help a patient get through their journey. When we optimize symptoms and support their psychological distress, we are in a position to enable them to undergo further treatment. So we are potential allies to your input with their care. I have had a unique situation in one of my previous jobs as a consultant up in the Northwest, where I was referred a gentleman with colorectal cancer who had liver mets. He was struggling with significant anxiety. He couldn't get himself to go to clinic, and it was a colorectal CNS who knew me well who said, "Could you see him, please?" So we were able to talk him through how to process what to expect and how he might wish to go through the experience of getting to clinic to enable him to have treatment. Thankfully, it was helpful, because this is because I have a background of having first aid skills in cognitive behavioral therapy. We were able to support his psychological anxiety, and he managed to get through not just hepatectomy for his solitary liver mets, but also the cancer treatment. And he used to keep coming back to see me just because he was really grateful for the opportunity of being able to manage his anxiety. So we do have different skill sets. The other thing we have to make sure we have is up-to-date knowledge about whatever illness we're handling. And we look after people with not just malignancies, with non-malignant conditions as well, because there are lots of life-limiting illnesses there outside of cancer. We have to stay abreast. When I first trained, I hardly saw women with ovarian malignancies or any gynecologic malignancies having brain mets, or prostate cancers having brain mets. But now, with fantastic advances in medical science over the years, people are living longer. Cancer has become almost a chronic illness in some respect, and we are seeing unusual complications that we've not seen before. I'm also mindful of the fact that ovarian cancers of certain types can behave like hematological cancers, where the patient gets really sick, you give them some chemo, and they might respond. So we do have to stay abreast with regards to knowledge, because at the end of the day, unless we're able to present everything to the person in front of us, we can't provide them whatever they need to enable better quality of life. And treatment does enable better quality of life through managing symptoms. So a palliative care specialist is very unlikely to say stop giving them treatment if that's likely to help the person in front of them. We find ourselves between two extremes, either saying, no, it's not time to stop that treatment yet, you need to continue, or you're doing too much, please stop. I'm involved in multidisciplinary team work within our trust. I sit on the nutrition MDT, so I'm usually come across gynae-onc patients who are referred for PN, and we have a discussion about is PN the right thing for them at that point in time. I'm also part of the ITU MDT and lung MDT, that's with regards to cancer. And from a non-cancer side, we support, or rather I sit on the heart failure MDT as well as a motor neuron disease MDT. So the reason being, we are able to look at the person's care from a holistic perspective, weighing up the impact of not just the physical side, but the psychosocial element, and support decision-making. Because we are mindful of time being of essence for our patients, we keep in touch with all the relevant disciplines through networking to enable the quickest outcomes and action plans for them. So networking is one of the key key skill sets for a palliative care professional. Patient advocacy and carer support. I've had at least 2 cases, maybe more, of young women with gynae-onc malignancies, single mothers with children who have struggled with ensuring ongoing guardianship for their child once their time ends or when death happens. So our role has been about encouraging them to think about it, supporting them to make those decisions. And that's just one example of where we would enable advocacy and care support. There is no palliative care specialist without comm skills, and we usually deal with the most complicated ones, whether it's supporting families with understanding why treatment is no longer effective or why a decision's been made not for surgery. It's a lot more challenging in certain areas. So I've worked in the Northwest before. My first job as a consultant was in Harold Shipman's Patch. The challenges there were quite different to where I am now, which is in Birmingham, where we've got a significant proportion of Afro-Caribbean Asian population, where culturally it's very hard for them to accept when it gets to the stage where ongoing hydration, clinically assisted hydration or clinically assisted nutrition is no longer in the person's best interest. So we're often called in to handle those conversations. We also handle difficult dynamics within teams. So those are the reasons why you might want to call for help if you want input from palliative care team. And as I said, I've given you the example of psychological support, and this is not just in the context of what I described earlier, helping a gentleman to go ahead and have treatment, but for some patients, it's just overwhelming, and it's a normal response to feel completely overwhelmed by what's happening around them, to the point that, as Tracy described, maybe that's one of the reasons that people find it very difficult to say yes to treatment that might well help them. So psychological support is what we provide for a lot of our patients and families. So supportive and palliative care indicators tool. Could I request a show of hands? How many of you are familiar with this so that I don't labor a point? Thank you. So this is a tool that would help you know whether it's time to call for palliative care or not. This was first developed by the University of Edinburgh in 2010. It looks at specific and general indicators related to life-limiting illnesses. I've snipped the document into 2 bits just to focus on the cancer side, but the conditions on here are cancer and all organ failures, essentially. The point is that if there are about 7 general indicators, any 2 of the general indicators and 1 specific illness-related indicator, if your answer is yes to those or they tick those, that means that they are going to need a careful assessment of their current treatment and assessment with a view to reviewing future care planning and calling for help to address unresolved symptoms, essentially involving palliative care where needed. So the general indicators are pretty obvious. People with deteriorating functional status, people who are becoming more dependent, multiple hospital admissions within the last year is a big red flag that we look for. And sometimes it's patients or families saying we want palliative care involved. And by and large, this is an effective way of knowing when to call for palliative care. How many of you have heard of the surprise question? Thank you. I've got 1 or 2 hands. So the surprise question: would you be surprised if this person were to die in the next 12 months? It was really encouraging for me to find that there actually is a paper in the Journal of Gynecologic Oncology from 2020 that's evaluated the role of the surprise question in people with gyn-oncology malignancies. So essentially, this was done in the US, 32 gynae-onc providers across 2 tertiary care centres were asked the surprise question about patients under their care having chemotherapy or radiotherapy. 358 patients were involved, and they charted their demographic and clinical information. Mortality data was collected after a year, or at 1 year rather, and they calculated the relative risk of death at 1 year based on the response to the surprise question. So patients whose physicians said, no, I wouldn't be surprised if they were to die in the next 12 months, had a 43% 1 year mortality compared to 10% 1 year mortality for those who said, yes, I'd be surprised. So in a nutshell, what they found is that there was statistically significant predictor, that was a good statistical significant predictor of 12-month mortality, and recommend that it effectively identifies gynae young patients with an increased risk of 12-month mortality. So, what next? Once you think, okay, they could be dead in the next 12 months, you might argue that a lot of your patients might be looking like that, but they will respond to treatment. That's fine. We're not saying don't give them treatment. We're saying help them understand that you have concerns, that you're going to offer them treatment, but this may or may not work. And it doesn't mean, as I said, keep plodding on. It doesn't mean stop everything. It means have a think about, could they return to their previous baseline with treatment? How long is their recovery likely to last for? And share that with them. Share that information with them, because then you're keeping them on board. They know what to look out for, what problems they might run into, and prepare them for the worst. What are they trying to achieve? So who and when should we offer palliative care to? Or with advanced gynecological cancers early in their disease journey to maximize benefit. And the other paper, which is very recent, 2024, was about initiating palliative care earlier than 3 months before death. Because what they found, again, this is a retrospective cohort study of ovarian cancer patients. They used linked administrative healthcare data to identify palliative care provision across all healthcare sectors and healthcare professionals, plus end-of-life care quality indicators. This is the JAMA paper, and they looked at the data from 2006 to 2018 in Ontario, Canada. And what they recommend is that if actually you initiate it earlier than 3 months, it's associated with lower death rates in hospital, late chemotherapy, ITU admissions, and aggressive care end of life. So being a bit more specific, as we said, doesn't matter what the prognosis is. Anyone with unresolved concerns or needs, cancer patients with pain that's difficult to manage, uncertain post-op recovery, those are patients that can be sent to us. Please be aware that if you've got a cancer patient with unresolved pain, you don't have to refer to the pain clinic. The palliative care specialist is more likely to understand the nuances around pain management for them. You can call on us if you need support to help your patient get home, and of course, people who are dying in the last weeks or months of life. So just to highlight what supportive care planning is, it's essentially looking into what would be helpful for them for ongoing care. Briefly skim on cancer pain management. It's incredibly important to ensure we know what the cause is, if it's treatment related, if it's disease related, because that enables us to focus on what kind of pain relief to use. More than 40% of ovarian cancer, women with ovarian cancer have problems with pain, and it's much higher, 70 to 75 in cervical cancer. Neuropathic pain is quite a problem, and the way to identify is the evidence is that opioids are still the first line to trial in neuropathic pain, and if it doesn't respond effectively to opioids, then you would try neuropathic agents. When you find somebody who has not felt that pain relief has been effective despite optimal titration, as in you increase their background dose of opioids and they're still using multiple PRNs of opioids through the day, and they're saying it helps them to sleep, then there's something else going on here. It's very likely to be psychological underlying distress that needs to be addressed. We call it otherwise total pain. So in the interest of time, I'm going to skip through this. The main thing to say is here, please don't hesitate to start somebody on long-acting morphine preparations. If the pain's really bad, we do not recommend going with immediate release preparations because they're more likely to have peaks and troughs with the drug in the system and more likely to be at risk of side effects. So it's absolutely fine to start somebody on 10 milligram BD of Zomorph or if they're intolerant to morphine, oxycodone is an option. Generally speaking, the most important things to look out for are EGFR, renal impairment. If they have problems with renal function, EGFR less than 30, we would use either fentanyl or alfentanil. We would use steroids if there's a compression element to it. Celecoxib or paracoxib subcutaneous are options for non-steroidal cover. Excuse me. We recommend being mindful of pill burden. Pregabalin twice daily is often better and has a better side effect profile than gabapentin. So that's what we would use for neuropathic agent. Interventional, I don't know how many of you have access to interventional pain relief in your units, because there are some places that are better equipped than others in enabling nerve blocks. Rhizotomy is basically surgical severing of the nerve roots to stop the conveyance of pain stimuli up to the brain. Radiofrequency ablation is one way to do that too. Going very quickly, the document that came out in 2014, as I said, was looking at the 5 priorities of care when people are dying. There's a report from the Sue Ryder hospice team in 2013 that identified 5 key priorities for people. Essentially, it's about making sure that they're comfortable, that their preferences are explored, and they're enabled to meet their wish to be where they want to be at the end. For about 63% from that report, they would like to die at home. And it's ensuring that we keep the patient and the family involved, supported through the process. If we're able to think ahead about their symptoms, a word of note about anticipatory medication. What we want is to avoid people being in distress when they're dying, so we anticipate those symptoms. So we anticipate pain, breathlessness, nausea, vomiting, secretions that might happen for various reasons, or agitation, and we ensure that medication is made available. It's really important that we speak to families and patients about what those medications are for and minimize their anxieties around the use of those drugs. There, just briefly, 2 cases. An 80-year-old lady was admitted with abdominal pain, vomiting, bowel obstruction features. She was known to have high-grade serous ovarian cancer. She had a CT tap that confirmed subacute bowel obstruction. Gyne-onc plan on day 2 was for maximum effort to be salvaged, with a plan for chemo, not for DNA CPR. The surgeons reviewed her on day 4, said she was too frail for surgery. On day 5, the gyne-onc CNS saw her and said she wasn't looking too well, deteriorating, we need to refer to palliative care. Day 6, she was reviewed and symptom management put in place, identified a preferred place of care, and she wanted to be as close as home to possible. That was facilitated. Now, this would have been the ideal scenario. Unfortunately, that's not what happened. What happened instead was, after the gynae CNS saw her, she was referred for TPN. Nutritional team, the CNS reviewed her and was quite concerned that her performance status was pretty bad. She had a sacral sore. And because the surgeons had said she was quite frail for surgery, the patient was finding it hard to know which one to believe, go for PN, not go for surgery. So I was flagged to the attention of the palliative care team. Gyne-onc consultant on the same day said, no, not for palliation, and planned for central line insertion, neoadjuvant chemo. The following day, the nutrition team consultant reviewed in person and said PN inappropriate. There was still disagreement about that from the gyne-onc team. So because I sit on the nutrition MDT, I reached out to the gyne-onc team and said, shall we do at least a shared care? We'll go along with you and address her concerns. That was declined at that point, but in the afternoon another review happened and the patient and the family chose to decline further active treatment. So finally, by day 9, palliative care team were able to see the patient, found that she wanted to be close to home, but within the next 3 days she deteriorated and we weren't able to support that. So what happened therefore is, because there was delayed acknowledgement or recognition of dying, despite more than one consultant saying, please consider this, we ended up not being able to control the symptoms in time and we didn't achieve her preferred place of death. This is a positive case that had a better outcome. In brief, we were able to get in there early, able to discharge her home, and she managed to spend 2 weeks at home where she died peacefully. I'd leave you to think about that. We all are in different phases where we want to do the best for our patient and we feel that it's really important to keep going, but there are, depending on who's seeing and depending on the training that we received, depending on the culture and tradition we all come from, we might have different reasons to feel that, oh, it's not time to call palliative care yet. And I think it's really important that we think about those elements that might stop us from calling for palliative care. So if we see it, please say it before it all caves down, crashing. This is a fantastic resource. You just need to Google West Midlands Palliative Care Guidelines. It's not just snazzy to look at. There's a lot of useful content on it, including symptom management and end-of-life care. And thank you for being patient and listening to me. And I've taken a bit of time than I expected. But I think, if anything, the take-home message is, please get in touch with your palliative care teams early. We can help in many ways. And if it's not the right thing, we'll be the first to say, sorry, not for us. We'll come back later. Any questions? Thank you.